everything on your schedule. I was not able to get here on time. Today we have probably the most difficult subject to cover in the resolution of poverty, but the issue that has the greatest impact, I believe, on poverty. Honestly speaking, I believe that if we could provide universal health care to folks, and it doesn't have to be universal health care in any particular form, but if everybody had access to health care, I believe that we would eliminate at least 30 to 40% of people of poverty and create a much healthier society. But with regard to focusing on issues of poverty, we would have a much smaller issue to deal with. We can't do justice from this perspective. We can't do justice to the issue of healthcare. There are so many balls juggling in the air as we speak. We have a new president coming to office in January, and the health issue is front and center to no matter who the next president is, and so we are sort of guided by whatever occurs at the federal level on issues of health care. But that doesn't say that we can't do anything about health care from the city of Los Angeles, notwithstanding the fact it's not in our bailiwick. It certainly, I think, is appropriate for us to engage in a discussion about what is needed in terms of health care and what the impacts to Los Angeles would be given particular programs. And so it should line up our political agenda, our policy agenda on a state and local, state and federal issues in particular. If nothing else, provide a greater insight for the direction we would support for the city of Los Angeles. And hopefully we can shed a brighter light on what the issues of healthcare are in Los Angeles so that we can help other institutions as well as ourselves craft programs that address issues of healthcare. So we're not trying to solve all the problems of healthcare. We're certainly not going to propose any particular form of healthcare. We do want to discuss some of the, and when I say discuss, I'm talking about the document of the master plan to end poverty in Los Angeles. We will feature those most prominent ideas to improve the healthcare system. But in any case, the discussion should help us get to a better understanding of the issue. And so the purpose of this hearing is to not just, we're not here to try and solve the issues of health care as it relates to eliminating poverty or reducing poverty, but we are here to incorporate a statement from Los Angeles as to how improvements to the healthcare system will improve Los Angeles and reduce the level of poverty. We specifically are asking each of the participants to review the draft and comment about the draft. It's not just tell us a global speech about what you think your issues of healthcare are, but specifically addressing how we should incorporate the thoughts into the document. Some people have a tendency in this committee to testify about all the great things they're doing, but they don't tell us how to change our document. And so we really want to focus that this is the purpose of this hearing and all the series of hearings that we've been having is to hone in on the written document that we are preparing on the master plan to end poverty in Los Angeles. So if you could tailor your comments to that would be great. Also, the advocates on healthcare are far and wide, and we can't possibly get all the programs. So we tried to hone in on some of the broader issues, and we'll just see where it goes. So with that, we'd like to convene the first panel, which is Beatriz Solis from the California Endowment, Rebecca Pisatola from the Director of Statewide Programs to insure the uninsured. Jan Perry, I understand her staff is representing her here today relative to the current state of healthcare in California and some of her radical ideas about changing the system. I like I like some of the controversy she conjures up. So with that, if you can step forward, and we'll start with Beatriz Solis. If all the panel members would step forward, we want to some extent have this as a discussion. So once you finish your testimony, please don't leave. We may participate in the discussion. Beatriz? Hey, Beatriz.
Yes, well, good afternoon. Thank you, Honorable Alarcon, for inviting the California Endowment to participate and comment on the connection between poverty and health. As a healthcare foundation, our priority is to examine the impact of social determinants on health, which poverty is one of those enormous social determinant factors that have a lifelong impact on not only individual health, but community health. And in addition, it sort of becomes...
This is your...
Our focus at the endowment has been on the social determinants of health. So when we look at a public health model and its connection to poverty, we look at key SES socioeconomic
This is in your
status.
mission statement? Or?
This is in our vision and the way that we do our grant making. And so we have a particular... Yes?
Maybe you should describe the
California
endowment as one of the health foundations. Was established after a negotiated process to allow your predecessor to become a profit-taking company.
Correct.
So, because I think that's very important,
Okay.
because that system has become more prominent,
Mm-hmm.
and in understanding the healthcare system, you absolutely have to understand how the foundations
Right.
and the process of moving from nonprofit to profit, and then creating these foundations, how that occurred, and that's something that we need to explain in our document.
Well, I think the beauty of community benefit agreements, and we can consider this one of the most important, I think, in terms of providing funding to community-based organizations as well as those safety net organizations, that the conversion of health plans from a nonprofit status to a for-profit status that was legislatively championed really had an enormous impact, not only in the creation of the California Endowment, but you also have the California Wellness Foundation, you have several other smaller foundations that also followed. You have UniHealth that focuses also from that conversion and focuses on hospital care. So part of the mission of the California Endowment, created out of that conversion from health plans converting to for-profit status, really placed the California Endowment, as well as our other sister foundations, in a unique position to focus on the underserved needs of communities in California. So our focus is California-based.
It's healthcare.
It's healthcare from a very broad public health perspective, which is not only, I sort of mention this purposely because I want to make the comment about the plan as well, which you had mentioned you would like to hear back from us, is that it's not just an insurance card. I think that what we've learned over the last 11 years, that even if you have a health insurance card, if you have Medi-Cal, if you have employer-based coverage, that in the end it doesn't sometimes make a difference for communities of color, in particular for African American and for Latino populations, or for immigrants or limited English proficient, where even though they may have insurance coverage, they may not have access to the services or the quality of services that they need, because inherent sometimes in the system is discrimination that may come out through policies and practices, or facilities and access to specialty care. So would you like me to elaborate more on the foundation? So
you were moving in the direction of addressing the document. So
yes, I think I really congratulate you in moving and making the deeper connection between poverty and health. I think sometimes we assume that that connection is inherent. And I think where I think the plan can really expand is looking at the broader environment. You mentioned, on your cover sheet, healthcare, nutrition, and environment. I think sometimes when we look at community health and when we look at communities that are faced with entrenched poverty, that we tend not to look at the factors that contributed to poor health in communities. So concretely, for example, if we think about the 710 corridor from the ports all the way to San Bernardino, if we think of all of those communities that are aligned along that freeway, you have the major activity of trucks, of traffic. You have a high degree of particulate matter that impacts the communities along that way. So what happens? You have schools that are along that freeway, and children that are having this are taking in this particulate matter, and that's lodging into their lungs. So you have higher increase of asthma, and these tend to be communities of color and low-income communities that are really faced with these problems. You also have problems with planning, which I think is part of that environment. Decisions that government makes in terms of where they're going to place their investments, where they're planning to develop affordable housing, where they're planning to develop partnerships with business communities. They really have a lot of opportunity to leverage for cleaner environments, either in the green buildings, either in contracting with agreements with ensuring that communities that are not represented that have access to those jobs. So I think those are really concrete ways to pull people out of poverty. I think in addition to that, when you think of the environment, it's not only the air quality aspect, which I think is incredibly important here in Southern California, but also the water quality, the quality of the community itself in terms of violence. We know that violence prevention efforts in the city are incredibly important, and that really impacts the health of communities. So when you think of environment, think of safe communities for kids to be safe and ready to learn, to have, either a safe passage to school or that the practices within the community really support youth. So I would say that part of the lens of looking at environment would be from potentially a youth perspective in terms of youth development, because we know that children that don't have the opportunities to be able to move forward, especially low-income communities, have more difficulty in terms of thriving and end up sort of with that cycle of poverty. So the other comment that I have is about nutrition. I think what we've learned at the California Endowment from our investments over the last 11 years is it's just not about individual behavioral change. I think you can pour, and we have poured money into health education, health information, but we need to go much broader than that, because if you live in a community that is a food desert where you don't have access to quality fresh fruits and vegetables, it becomes very, very difficult to have access to nutritious foods. So we know that in many areas, if we think of pockets in South LA in particular, they have been designated as food deserts because you don't have, full service supermarkets. You have a plethora of small, markets that may not carry the best array of fresh fruits and vegetables. So again, thinking of nutrition in a much broader way. In terms of policy and systems change, I think the opportunities are to look at where government can contract with quality food vendors. We know that in our investments within schools, for example, really pushing for quality foods for kids in school. So their lunch programs, the breakfast programs really help increase and improve nutrition of these populations.
Did you have a chance to read the draft? And are there places where you saw this reflected, or do you have suggestions as to where we might insert or expand on some issues?
Yes, I think the section on, if I think about the first section in terms of healthcare, it's very elaborate about the focus on health insurance. I think going section by section, one thing that we've also learned is that the healthcare system per se does not necessarily invest in prevention. And I don't necessarily mean in prevention in terms of access to, mammography or, sort of a screening test, but really investing in prevention. So you're going a bit more upstream and you're preventing disease from occurring. So I think
to try and capture it in the sense of this being a city document, notwithstanding the fact we don't have a health mandate per se, we have a responsibility to incorporate into our planning process and our building and safety process, our development process, factors that would create healthy environments to produce or to lessen the negative impacts that create healthcare problems in our community. I don't think we've ever looked at it from that perspective.
And I think the other thing...
when we're making decisions, the community will come out and say, we have high asthma rates in this community and we don't want to put the whatever plant over here, or the landfill over here. That's in my community, that's what happened. But we don't look at it from a health concern as much as we look at it as an environmental thing separate and apart. But the purpose of the environmental improvements is clearly to impact our health.
Right.
And so we have to have a much more focused view. And I think I'm interpreting you to say that you want us to sort of expound on that notion.
Well, I think that's a great opportunity, because if we think about just the area of the connection between housing and health, we know that from our investments here, in particular in Los Angeles, looking at the connection of slum housing on health on children and adults, it's enormous. The evidence is very clear that when you have infestation of rodents, of cockroaches, et cetera, that contributes to increases in asthma and other respiratory problems for children, and especially fragile adults that have chronic disease. So I think in terms of how the systems change that can occur is really enforcement. We know that there are laws that are already on the books, but really making that connection with the inspectors about being aware of those connections, of how they need to pay attention, because we know with many of these areas with entrenched poverty, just in the city of Los Angeles, you have high older housing stock, so you still have lead as a problem. The best science that's coming out right now is demonstrating that even the most minuscule amount of lead that a child ingests has an impact on their health and their ability to learn and to thrive and for brain development. So I think the connection between the policy and systems change in housing, for example, could be sort of related as something as a vehicle for making that stronger connection.
Well, not to take all the time on that particular subject, but we would want to work with you in helping us craft that notion into the document. And even to, I think, the extent of exploring the feasibility of establishing goals. How many cases of asthma can we reduce by cleaning up this neighborhood? And I don't think we've ever approached things from that perspective. It's like on our the home ownership issue. I've often raised the fact that we're losing home ownership in Los Angeles and California. The California dream of owning a home in Los Angeles isn't a reality. As 70% of the people, probably more after during the foreclosure crisis. But at what point does that start breaking down our social health, public health issues? Certainly, one of the things you need is collateral to be able to pay for health insurance or health occurrences of health need. And you might need that house to get a loan. And those people that have it would use it, and the 70% that don't slip under, and they fall backwards. But those are some of the notions that we would appreciate your help with. What other ideas?
I guess the other one thing that we have learned, the endowment in 2003, we put in our board recommended about $45 million dollars to begin to address the needs of children. We felt that there was at least an opportunity to cover children, that there would be some synergy, some attention, some focus on at least covering kids in California. And we've continued those efforts in the children's health initiatives by counties. And again, there are counties that are more receptive to participating and to, it requires a partnership between the public and private entities. However, what we've learned is that it just makes it extremely difficult because the majority of kids that we were covering were kids that were undocumented kids. And so we knew that, regardless of their status, regardless of if their parents worked full-time, they were not going to get access to full-service Medi-Cal or healthy families.
The parents wouldn't want to sign up for the program.
And so the program has been very successful, but what we found is that there has to be a broader, and we agree with your statements, is that there has to be a broader sort of system change in terms of how we view sort of how health insurance. So a strategy that we've taken is really to strengthen the safety net. And the way we look at the safety net is in terms of FQHCs, federally qualified health centers, or community clinic lookalikes, because they're really the engine and meet the needs of the community because they're in the community, and strengthening them so that they're able to draw down dollars from the federal level, from the state level, to be able to serve those folks that don't have any coverage at all. So we found
that one of the immediate needs would be to expand on services provided by the community clinics.
Exactly.
Which barks right up my alley because
Exactly.
Gil Cedillo and I did the Primary Care Clinic Act, and
Mm-hmm.
interestingly, John Garamendi provided $35 million from the negotiation of the wellness agreement to WellPoint, I should say, deal to direct it toward the Primary Care Clinic Fund. And it's interesting that we come full cycle and you make that
Mm-hmm.
statement, but I'm well aware of that. And so I think it's a sort of a stopgap measure, the community clinics. But when I say that, until we figure out what exactly the system is going to look like,
Mm-hmm.
because I believe that because the community clinics go right into the communities that they serve, we're always going to use them.
Mm-hmm.
We're always going to need them,
Mm-hmm.
no matter what system we eventually
Mm-hmm.
settle in on. I believe the community clinics will be present because they're they're the closest to the community. And so we should build around them in the sense of building support for those clinics.
And I think because they also have the ability to innovate. They are able to innovate in a bunch of different areas. And they look at the medical home in terms of not only providing primary care, but looking at the needs of the community, whether it be through substance abuse, job training, after-school programming, preschool. So a lot of innovation of the community clinics is really on the ground need of the community, so they really have that pulse. I would say my last comment, although I can continue commenting, would be on thinking about food access. I think one of the things that we've also learned about food access and food quality is also the role of obesity, which you call out. And I think where city government can play an important role is in, again, going back to planning and parks and recs, having joint use agreements, opening up safe parks in communities. Because we know if we think of Boyle Heights, right next door to us, folks were walking around the Evergreen Cemetery because that was a safe place for them to walk around. And we know that that is occurring in many communities. But again, if we think about it, really placing a higher value on places for people to get together as a community so that you have elders and young people that are able to go to parks and safe places so that they can recreate and sort of beat the obesity epidemic. Because I think my fear is that the healthcare system cannot deal with the obesity epidemic. I mean, again, it would be sort of a medicalization of it, when in reality we really need to have innovation in terms of how government can influence community planning so that the voice is heard. Right now the city is in a very exciting process. The RALA is out there generating these community plans. We have funded some community organizing groups to influence in those plans so that they can participate in the vision of communities that have broader sidewalks, have better lighting, have safe passages to school, that have affordable housing, because all of those contribute to a safe, quality community. And we know that low-income communities in particular were not at the table to have their voice heard in terms of being able to articulate what a safe, quality community can be, as opposed to having developers having that agenda and having that access. So I think the ability of ensuring community engagement, participation in terms of how they can create a community. I think low-income communities, even in South LA, you see, Community Coalition has been working very hard at trying to broker agreements with the local schools to reduce violence, because the youth in the schools have been reporting very high rates of post-traumatic stress syndrome related to poverty and related to violence in their community. So you're having a large mental health issue that's cropping up. So I guess sort of expanding that purview of how policy and systems change from the city perspective can really be a boost to broader community health.
I'll give you an interesting anecdote. Because I have created for my own office a child safety agenda, and one of the items on my agenda is providing speed humps around every school and every park as a priority until we catch up. We're far from it. When I presented that notion in the Transportation Committee on a grant related to safe passages to schools, the initial response from the Transportation Department was that has nothing to do with safe passages to schools, and the state would not fund it. Well, through political pressure, I was able to get it on the list. The state funded it. They saw very clearly that the nexus between slowing cars down around schools and making kids safe to school. And so I'm going to get 30 speed hump projects in my school when when every council district gets 3 a year from the city. So, but it's the notion of being able to impact something beyond the immediacy of reducing traffic accidents by slowing down cars, which is the purpose of speed humps, and expanding it to the notion of making kids safer, because there's high volumes of kids around schools and parks. But that's the kind of thinking that I think you're trying to express, that even though health is not in our bailiwick, we can keep our community safer. The other interesting thing on the access to food, as the city becomes more prominent in LAUSD, and I believe we will continue to be more and more prominent as time goes on. It would be curious to me to know how many kids in our school system rely on the food that they get at school as their prominent diet, and how we might enhance the opportunities to avoid processed foods and give them healthier foods. So that again, it's an area that I think is well worth incorporating into the master plan.
Right, and there's a lot of innovation in terms of creating school gardens, not only incorporating the knowledge around school gardens into the science curriculum, but in addition to that youth get involved with growing the food for the community, and having parents engaged in the community garden as well has been a very prominent uplifting of information that we've been getting from our investments. Another piece has been looking at the footprint of how food is delivered in distribution systems. So we had funded Occidental College in their urban studies department to look at the footprint and distribution of food patterns within these communities. So that's another area that could potentially be focused on in terms of, where are schools getting their food from, and are there ways to connect local farmers to schools? So bridging fresh fruits and vegetables, you're supporting, local farmers, as well as bringing quality foods to the school. So I think there's opportunities
Well,
there.
we're
as
going to
well.
move on, and I'm sure you have many other things to offer our master plan. We encourage you to please do, and we don't have claim on this document to the extent that we want to avoid other people's ideas. We want your input, and even to the extent if you want to help us write it, we're happy to work with you. We give you editorial privilege.
Well, we'll take you up on that.
Well, thank you. No, we appreciate it. And so we'll move on to our next presenter as soon as I can catch up. Rebecca?
Yep.
Pizzatola.
Pizzatola, yep.
Good name.
Well, I work for Insure the Uninsured project, and what we do is look at local, state, or even national models of expanding or otherwise improving the healthcare system to cover more of the uninsured. So today, after reviewing the document, there's a small part on what will be page 5 that talks about Healthy San Francisco, one of the local government reforms. So what I wanted to do is to really go more deeply into that, but I wanted to first get a sense of what you know about Healthy San Francisco. A lot of it's now in front of you in that document, but I don't want to repeat if I'm speaking to the choir here, preaching to the choir.
I wouldn't assume. My staff knows a lot more than I do. But,
Okay.
But also the masses of people who are listening to this may
All
not
right.
know anything about it either.
Well, then I'll first just thank you again for having me here today. And so what I'll do is delve a little more into Healthy San Francisco. And I guess just in terms of speaking to editing the document, one, I'd love to edit it. I love editing. And two, Healthy Healthy San Francisco is only one of the many local models for reform that, even though Beatrice said that a health insurance card is only one part of poverty, it is still a part to look at. So diving in, I'll just say that Healthy San Francisco was started in 1996 under the Healthcare Security Ordinance. Uninsured individuals typically have no usual source of care, and they tend to delay their care until their health gets worse.
Now, can I ask you something? Because
Sure.
we know that San Francisco is a city county.
Yeah.
Was it started on the city side or on the county side?
Actually, I'm not.
City.
Okay,
Was
sure.
the city.
It was the city side?
City.
But they are known for their strong
Somebody's-
collaboration.
Who are you and why are you nodding no?
Howard Kahn from LA Care. There's no real effective difference between the two in terms of how they operate.
Oh, okay, so,
The city
really?
and the health director, that's
Oh.
what I'm shaking my head.
Oh, okay.
Yeah, and that's what makes them unique and different from LA, but they still have experiences that we can probably learn from. But either way, let's see. Okay,
But I guess the point being that that San Francisco has a definitive role in health policy
Yeah.
and implementation of programs.
Yeah,
As opposed to Los Angeles, where we don't have much.
But we're strengthening what we have. I mean, right now we have Section 115 or 1115 waiver that is called Healthy Way LA, and 9 other counties have coverage initiatives right now going on, including San Francisco.
But I'm speaking about the city of Los Angeles.
Yeah, but I mean, we're working on ways to strengthen our network. I mean, she said we have to focus on clinics, and part of the Community Clinic Association of Los Angeles is working on strengthening those partnerships. A public-private program also brings together private and county clinics. So if we strengthen our network, we can look a little bit more like San Francisco, and maybe a little while from now have something that works better. So essentially, the San Francisco Board of Advisors adopted this ordinance to cover more of the uninsured and cut costs for caring through them through emergency rooms. And as part of this ordinance, what they did is create something called the Healthy San Francisco program, as well as have an employer spending requirement. And what this requirement did is for nonprofits with 50 or more employees, or for-profits for 20 or more employees, it required that they spend a certain amount of money per hour for workers working more than 8 hours per week, well, 8 hours as of January 1st, 2009. And what this amount was $123 for up to 99 employees, or $185 for 100 or more employees. You look like you have a question.
Is that per hour?
Yes. Yes, but they do have a cap of 172 hours per month. But either way, they had an employer spending requirement.
Actually, I was trying to remember, maybe you remember, John, what the city has certain wage rules that,
With the
if you have health insurance.
living wage?
Yeah.
Uh,
Doesn't
It's
it?
a lot less than that. Yeah. It has not been indexed either.
Right. What you mean by living wage, mostly on development side.
But there's living wage if you have health insurance and living wage if you don't have health.
Correct.
Okay. Do you know what it is by any chance?
No, I don't. We can find out for you, though.
Okay, so, but
I mean, I
the
think-
precedent is there.
What'd you say?
The notion is there.
Mhm. I mean, San Francisco is unique again, but this is just something to give you a basis for what this program looks like. So what this program did is mainly affect low-income workers. So we had a big backlash from the restaurant industry. So there was actually a lawsuit filed because of ERISA, which forbids states from regulating health insurance benefits. But at the end of September, San Francisco actually won this case with the reasoning that they weren't really regulating benefits so much as telling them to play a part in their health care and offered them options of ways to put their money. Either you can provide benefits, you can pay the city, and we'll help put them in Healthy San Francisco.
What level of court was that?
It was the U.S. Ninth Circuit.
Court of
Yeah,
Appeals?
yeah.
Okay, and
So
is
who
it being
knows?
challenged?
According to news articles, yes, it is being challenged again. But they're still moving forward as they have since the first challenge.
Okay.
And so either way, like I said, they moved forward, but what they did is they were doing a lot of piloting to see how the program would be effective. And they were also enrolling people slowly, which they continue to do today, about 600 enrollees per week. Initially, they started covering those under 100% of the federal poverty level, which is a little over $10,000 for an individual per year. And then they moved it up to 300, and by January, they hope to open it up to 500% of the poverty level, and after that, open it up to all of the uninsured who do not have public or private access to health insurance. And so one of the biggest strengths is they really blossomed from collaboration among so many different partners.
500% of the poverty level?
And then beyond that, if you don't have access to insurance, which might...
That would be like $100,000 or something.
Yeah. Mm-hmm.
For a family of four. What?
Yep. Yeah, it's pretty much 101,000, exactly. So they're really just trying to be very innovative and very extensive. So what they're doing is they're not providing health insurance. What they're doing is something called providing health access. And what this really means is they're not providing health care outside of city limits. And they're providing this care on a sliding fee scale according to where you are in that federal poverty level. So for people under 100%, they don't have to pay anything. But if you're, say, 500%, you pay somewhere around $700, maybe $600 per year per enrollee. And then other additional costs for things like prescription drugs and then co-payments for care. So what the program seems to cost is about $200 million a year, and the majority of this is actually...
It seems to me that it's merely a competitive system for the private market.
It is, but
So,
they...
I mean, you still retain the choice to go to a different doctor, but it seems
Yeah.
that you've set it up so that you're competitive and they may want to go here because
But I
it's
mean,
more
they have the
affordable.
collaboration. They have the San Francisco Community Clinic Consortium, which are private clinics, and they're working with the Department of Public Health. So it's really a public-private model anyway. So they're competing with a collaborative spirit anyway. So it's not really geared to ruin the private market in any way. At least it hasn't shown up in any articles
Okay.
yet.
Interesting.
But so far, the program is costing about $200 million per year, which, considering the amount of enrollees, is about $2,700 per enrollee. The city pays for more than half of this by just shifting dollars that were already being used to care for these people into this program, making it more streamlined. And they also are getting some money from the Healthy Way LA, the coverage initiative I mentioned before. And then a very small portion is actually coming from the employer spending requirement. It's somewhere about 14 to 15% of the cost is covered by this.
I'm intrigued by this, the 500% of the federal poverty level because you're really not addressing it from a perspective of poverty. You're dealing with it from a perspective of creating a competitive model where people still have to pay on a sliding scale, but But it reduces the cost to everyone.
Well, I
would
guess maybe I didn't mention it, but the part that prevents them from, if they already have an option through their employer, which might be likely if they're making that much money, then they can't qualify for this.
Oh, okay.
So that's really the part that protects them.
So it's just, it catches it's a safety net for those.
Yeah, I
who
mean,
don't
say
have-
someone just is not able to be insured, they don't qualify
Now,
for the
has
employer at
the
all.
business community eliminated their insurance plans because you have this? And
No.
just tell their
No.
workers you can go.
I mean,
there.
a lot of people are signing up for the city option, which is what it's called. So if they weren't providing insurance before, they're saying, well, I still am not going to, but here's the money that you're requiring me to pay. So either enroll them in Healthy San Francisco or put this money in a medical reimbursement account. But so far, there hasn't been any crowd out, any dropping of the private insurance.
Mhm.
And it's mainly just because you can't do that because those people wouldn't be eligible otherwise. So.
Thank you.
So just looking a little more deeply at the difference between San Francisco and LA, San Francisco really made this program work because they had a strong foundation of employer-sponsored insurance. So a lot of people were already offering insurance to their employees, so they couldn't drop it and just push them into this system, at least without letting some time pass. And they also had a pretty strong safety net. And unlike LA, they have a very compact geography, so people can access a lot of their clinics. I mean, they have a good number of clinics anyway, but either way, the population can access something most likely in their neighborhood. And they also covered most of all of the children in the city, so the next step for them really was just to cover the uninsured adults. So they drew on this foundation of coverage, and it was supported by what some call unique political culture of healthcare being a right, and they also had somewhat of a sense of solidarity. It was also a small step in comparison to places like LA. San Francisco has 14.5% of its population uninsured, compared to us, it's 23.5%. But just so you know, this program of health access is open to undocumented immigrants too, so that wasn't really a consideration. They also have something called the San Francisco Health Plan, so they do have a managed care model. And we could look at options too, such as LA Care Health Plan in LA for something like that. And the San Francisco Health Plan actually has a lot of experience serving low-income populations because they were started in 1997 specifically for Medi-Cal, and since then have expanded to managing things like healthy kids and healthy families and healthy teens, I believe they have a program called. So they really could use the San Francisco Health Plan to try to keep costs down, to try to look at utilization, look at all the data, help with enrollment and outreach and things like that.
You know, in a Los Angeles program modeled after this,
Yeah.
County is providing a certain level of service throughout the county.
Right.
The question is how much of a gap exists in Los Angeles City, and what might we contribute to close that gap?
Mm-hmm.
It's an interesting notion. We've never really, I think we've funded through our community development block grants health-related services, but I don't think we've ever looked at the approach of funding 100% of our kids.
Yeah.
So you might be supportive of a motion to have the chief administrative officer meet with city administrative officer, meet with the county administrative officer to explore the feasibility of providing 100% coverage for kids up to the age of 12, and close the gap between what the county provides and what it doesn't provide.
Well, for sure, because also that population is one of the cheapest to cover, and it's also, if we're looking as a country in general shifts their ideology
I'll do
towards
it.
prevention. I mean, you want to start early and prevent things from getting worse, so starting with kids makes the most sense.
I think that I recognize the controversial nature of the subject, but the discussion is something. And the first thing is that in the purview of the city of Los Angeles, and given the worst economic crisis we've ever faced. But to have the discussion, I think, is and the thought and the vision is, I think, essential to our future.
Yeah.
It costs us a ton of money in crime prevention and a whole assortment of other things
Mhm.
because of the health needs of our community that aren't being addressed by the county. So I'm certainly willing to enter into the discussion.
Yeah, and I mean, just one of the special things, at least, that we can't do immediately is San Francisco, since they are a unified city and county, they were able to do this payroll tax on the employers without much of a hassle. Of course, ERISA came up, but before that, typically counties can't have that sort of tax legally, so that is a barrier we'd have to work with as LA. So we'd have to look at different financing options, but as I mentioned, only about 15% of the funding was coming from employer-sponsored insurance or employer spending requirements. So just looking a little more deeply into LA, we see things like I mentioned, the public-private program. We have a fairly strong network of clinics that is only going to get stronger under Healthy Way LA, which is the coverage initiative. We also have Healthy Way LA, which is really piloting a lot of the things that we need to move in the direction of. For instance, they are strengthening the clinic partnerships, and they're also using a medical home model, which means that you have each patient designating a certain clinic as where they go for most of their care, and that clinic coordinates their care, which means that they're not going to have duplication, they're not going to have the same test twice, they're going to have tests that they need to maintain their health before it gets to the point where they have to go to the ER. So this is really a model that Healthy Way LA can pilot for us to follow in the future. They're also looking a lot at disease management, and they're also, most importantly, also using health information technology, which even though a lot of the clinics don't really have medical identifiers for their patients that match up quite yet, they are still using information technology to refer people to next day visits instead of going to the ER, to just link people up, link providers up, and make sure that care is more coordinated. So we have to also look at health information technology. And like you mentioned...
Well, this is an interesting model. The way that we're crafting the document is we are including, what, for lack of a better term, what we call anecdotes, inserting them into the document, as you might have read, stories about people. But we are also including anecdotes of particular solutions as ideas.
Well, I think what would be interesting to add is just sort of the difference between these are the elements that helped San Francisco succeed, at least to date, and these are the elements that LA already has, and these are what we need to do. For instance, we need to unify the city and the county a little bit more, just to get them talking a little bit more. As hard as that seems to be.
Well, I think the way that we would incorporate something like this into the master plan would be to sort of have an addendum that could be referred to, and actually work with you to write the document so that we not only talk about the way San Francisco does it, but how we may create a model that's based on that model in Los Angeles, and which, what the steps might look like to move forward with that discussion.
As well as looking at counties that
as opposed to incorporating it directly in the body of it, it would be an addendum. We refer to it in the body just to
But if you think San Francisco isn't really the best one to mimic, I'm sure there are other counties that look a little more like LA that are doing pretty
Well, I don't know that we're
innovative
going to
things.
have, how many is it, 39 of these? But
well, I mean, there are
but you
those
offered.
10 counties doing initiatives. Orange County's doing it, San Diego, places like that. So they're all just looking at
we
prevention.
should reference those as well.
Yeah, for sure.
Well, thank you very much.
Thank you.
Okay, and now from Jan Perry's office.
Good afternoon, Councilman. My name is Kathy Godfrey.
Supervisor Perry, right?
No, pardon me?
Supervisor Perry.
Yes, that's right. Whatever. I'm here to speak on behalf of Councilwoman Perry, and I actually asked Ruth Schwartz to join me here today from Shelter Partnership because she has access to so much research information that I think you'd find interesting beyond anecdotal information. And she wanted me to speak to you today about the people that we have attempted over the last 7 years to bring better services to because of the impact of homelessness and chronic homelessness in the city of Los Angeles. And the issue for us has been how we have dealt with the county, both on the public health side and the mental health side, and the frustrations that we've experienced in terms of the city really stepping up to put systems in place, continuum of care in place, to help people, but without the county support, it's been very difficult to make the kind of impacts that we really wanted to make, both as it includes chronic homelessness. About 35% of the homeless population in our region is mentally ill, and a high percentage of that with dual diagnosis. So with starting many years ago, the first thing that was done was the creation of a year-round emergency shelter program. And we wanted the county to integrate their services at the shelter program, but we were informed that we would do well to hold a fundraiser for that. So having said that, we continued with the year-round shelter program and integration of services. And after Ruth's advocacy from Shelter Partnership and working hard, we finally have county mental health integrated into the year-round shelter, the largest year-round shelter at the New Image Emergency Shelter. We asked for public health services as it pertained to, at the time, you probably recall, portable toilets existing on the streets of Skid Row as a means of, quote, advocacy and providing services to the homeless and the removal of those. And we hit numerous barriers in terms of public health services not wanting to assist us. Jan actually asked the head of public health at the time to write a public health emergency order instructing both the city and the county to do something about the homeless on the street population, which at the time was climbing into the thousands. The city went, pardon me?
No, go ahead.
Yeah, in downtown. Downtown for many decades has been the repository for the region's homeless problem, largely because we have the highest concentration of homeless services there. We have the Los Angeles Mission, the Midnight Mission, the Union Rescue Mission, and about 70% of the service delivery there is for single adults. County Department of Mental Health Services is there, and they have varying rising and falling funding levels based on what the county's financial situation is. With the advent of the Mental Health Services Act, we were extremely hopeful that we would be getting more than a fair share of what this population needs in terms of mental health service delivery. But when the county presented its first Phase 1 plan to the Board of Supervisors and to the state, there was little to no provision for persons, the homeless mentally ill population. That was not the focus of where they wanted to spend their resources. The councilwoman went before the County Board of Supervisors and asked that change, and also before the State Oversight Commission, asking that they not adopt the plan that had been submitted by LA County, because we felt it was so wanting in terms of serving this population that were being so heavily impacted by it, the city. Both the board and the state adopted the county's plan. But I think there has been some changes made to the plan, and effective changes based on Jan's advocacy and pointing out to state office holders and so on that this was basically and fundamentally unfair, and it was also being done in a manner that was going to continue to hurt the city and hurt the public health, and certainly the interests of the community that is Skid Row. And I might add, at the community level, we have 700 children living at or near homelessness in the Skid Row area community. We also have it's still considered a repository for the sheriff, because he sends homeless people being discharged from the jails, no matter where they were arrested in the county, into downtown. And currently we have about 3,600 state parolees, because state parole relies on these services as well. So we face numerous challenges based on the systems that continue to believe that if individuals are homeless, they belong in downtown Los Angeles. This includes families. The county embarked on a program for homeless families that was funded through Gloria Molina's office to look at homeless families and to turn the business of homeless families being deposited in Skid Row, because it's not a very good environment for families. And this program is now 2 years old, and it put a number of homeless families into housing of a sort and has been studied, but it's my understanding that the funding for that is now being removed. It's not going to continue to be supported. I don't know if homeless families are going to continue to grow in downtown as a result of that, but it's a problem. There is a long practice of behavior of LA County Health Services and Mental Health Services of funding new programs, pilot programs, demonstration projects, and then not continuing the funding. I think it was the California Endowment that funded a service van, a mobile health care van, to go to our emergency homeless shelters in the winter shelter months. It operated for 1 year, drastically reducing the need for paramedic calls by nearly 50%, therefore keeping homeless people out of emergency rooms. But after 1 year, the county didn't pick up and fund the program. It sits in the parking lot at JWCH. So we have for years gone through this process of not having our share based on the funding formulas at LA County. We have 46% of the homeless population. We don't get 46% of the funding. It's always done by the rule of 5. The county established the Homeless Prevention Initiative, allocating $32 million for new homeless programs, and it had to be divided by 5, and each supervisor was to get an equal part of the sum. We actually applied for a program under that initiative, but we were declined. Our proposal was not adopted or funded. There were supposed to be, under the Homeless Prevention Initiative, 5 county stabilization centers for homeless families, homeless people to go to throughout the region in this effort to, quote, regionalize.
Okay, let me. I'm going to insert myself here.
Yeah.
The reason that I asked Jan to participate in this hearing is specifically because of the notion that she has presented to form a county in the city of Los Angeles.
Mm-hmm.
So, I mean that's a radical idea.
It is a radical idea. I think when we look at all of the problems and challenges we have faced in terms of a fair share allocation of funding for programs in the city of Los Angeles, including offering numerous opportunities for the county to participate by providing mental health services in our shelters, providing service dollars in the city's spending millions of dollars to establish permanent supportive housing. We have no guarantee that we're going to get the supportive funding through the Mental Health Service Act for the services in that housing, even though that is a huge response to chronic homelessness here, and using the lion's share of our rental subsidies for that as well. So why shouldn't we receive the service dollars? Because those are the dollars that will help keep people in this housing. So as she started with building a continuum of care for the homeless population and automatically believed that the county would step up and incorporate their services, and it hasn't happened. And in a response to poverty at this level, the county effectively, the general relief sum hasn't changed in 20 years. It's still $221 a month. That's a 20-year, nothing has changed there. And they have a backlog of thousands of cases of people that are entitled to SSI and SSD who are not getting the entitlement. If they did, it would save them millions of dollars in general relief. But their ability to respond to these kinds of needs and get those services where we have people, if you're going to qualify people for SSI, SSD, you have to produce the mental health records, you have to produce the health records, the disability records in order to make them qualify. We offered a program to the county which would have required very little funding, in fact, to put public counsel in the emergency shelters, because we did put the health care, we do have the mental health care, and qualify them.
I'm trying to get a sense of whether this is a proposal to expose the.
Well, I think these are the examples.
My statement.
Yeah.
Whether this is a proposal to expose the inequities that you're reporting in the system, or whether it's a legitimate effort to make the city of Los Angeles a county,
Mm-hmm.
which includes other ramifications. I mean, the penal
absolutely.
system, does that mean we have our police officers are then sheriffs?
I know it's an enormous undertaking, and maybe it means there's something that can be done incrementally under your proposal for health care, or how health care is delivered.
Use the county tax dollars to Los Angeles.
That hasn't even been examined. There would have to be, I think, a state legislative process that would be undertaken according to the CLA, I believe, that to examine all of those things, similar to what the Valley underwent when it was considering, separating from the city, what those impacts would be. It's not a small, it would be an enormous undertaking. The question is, what options does the city have to get more of a fair share of what we need to deal with the problems that we have associated with poverty, extreme poverty and homelessness, mentally ill homeless, chronically homeless, because those are the issues that are really impacting specific areas of the city.
Bringing it back to the document,
Mm-hmm.
Clearly the discussion about homelessness, it's a fair question. It's a fair, I think, opportunity for us to talk about some of those core issues with
Mhm.
homelessness. So we want to work with you to
Great.
help us. Again, we could add an addendum on the homeless issue itself
Mhm.
and talk about this is the health portion, which I know you consider your work to be in. Whether we put it there or in some other section, the point
Mhm.
is, I want to provide this whole notion about city-county responsibilities and whether the city is able to effectively deal with its homeless problems, and where we feel there might be a shortfall from the county,
Mhm.
and incorporate them in the document.
It's great. I brought you a couple of studies that were done by Michael Cousineau.
I don't read studies.
Okay, but for your staff to read.
But actually.
It has an answer to a lot of your questions about health
Actually,
care
I'm challenging
and mental
you,
health care.
or I'm giving you the opportunity to help us write it directly.
Good.
I mean, I can't have my staff write every section of this.
No.
If we're going to do a good job.
Mhm.
But I don't think any council member has a better handle on the issue of homelessness than Perry, for obvious reasons. And,
Mhm.
and I think that, that we should have a significant statement about homelessness, and this should be a significant part of that. So.
Good.
So we just say, thank you for your continued advocacy. Please extend that to the council member. But
Sure.
More importantly, can we incorporate that advocacy in the document?
Absolutely.
To end
Absolutely.
in Los Angeles.
And
I'm not making any statement that we agree 100% on
Mhm.
everything. I'm sure there's something we don't agree on,
Mhm.
but the point is, we should have that discussion available for
Mhm.
and incorporated in the master plan.
Yeah. The other thing that I would like to mention, too, is that she's made an effort to get mental health services integrated in the public school system in her district at the high school level and so on. And Department of Mental Health at the county does have contractual agreements with some cities like Pasadena Unified School System and so on. But there's a disagreement between the LAUSD and the county council on.
That's hard to imagine.
Yeah. So they haven't been able to come to an agreement on, but it would be a wonderful thing to have in the high schools for violence prevention and crisis intervention and the kinds of things that a lot of kids living at poverty do need in terms of interventions. But it's been very difficult to get that.
One thing this brings to light is the need for better coordination and cooperation and understanding between the jurisdictions that have these integrated roles.
Yes, as this unique political culture. That's what was said earlier. It's a very unique political culture. I think that's what it is.
Where San Francisco is a city-county, we have 90 cities or thereabouts, and and huge unincorporated areas that make us unique as well.
Yeah, exactly.
So, well, thank you very much.
Yeah.
And I'd like to move on to the next panel. Are there any questions? Any answers? I hope that
Any answers?
I hope you will continue to participate with our master plan development, and I really appreciate your input.
Thank you.
To the staff.
Did this just fall out of my briefcase?
What is it?
I'm sure it is. Okay. Okay, now the community clinics. We've heard a lot about community clinics. We have a whole bunch of folks who represent the community clinic system. First of all, Howard Kahn, President, LA Care, Corinne Sanchez, President and CEO of El Proyecto del Barrio, Luis McCarthy, Vice President of Government Affairs from the Community Clinic Association of Los Angeles County.
None of those individuals except for Howard are standing before you.
Corinne is not here.
Corinne's not-
You're Corinne.
I'm not Corinne.
Corinne's not here.
Are you represented here?
No, I'm Louise McCarthy.
You're
She's on the
Louise.
list.
Corinne's
You're missing
one of my
one.
members.
Okay, Corinne is not able to make it. Is Lark Galloway here?
That would be me,
That's you, okay. And Howard Kahn.
Howard.
Okay, that's it, right?
Right.
Okay, good. Okay, so we're going to start with Howard Kahn.
Good afternoon.
Good afternoon.
I'm Howard Kahn. I'm the CEO of LA Care Health Plan. Let me take just a moment to tell you what LA Care is in very, very high-level terms. We're a public agency. We're an independent public agency that serves the County of Los Angeles. We're also the largest public health plan in the United States. We've got 750,000 members in LA Care, all low income, all either on Medi-Cal, Healthy Families, or the Healthy Kids program that we created, and then a new...
You said an independent agency.
Right.
Tell me a little bit about the government.
We were created through state legislation, enabled through state legislation, created technically by the County of Los Angeles, but independent of the County of Los Angeles. Our board is nominated by a number of safety net and other providers from throughout the county, so basically stakeholders.
Essentially, they have a contract with you?
We have a contract with the state of California for Medi-Cal. We have one for Healthy Families. Our relationship with the county is interesting. It's a close one in that they approve the nominees to our board. And the nominees from our board come from everything from the Community Clinic Association. Our current chairman is Jim Lott, who's from the Hospital Association. Don Kanabe's been serving on our board for the past 7.5 years. So it's a stakeholder board, as I say, hospitals, doctors, various stakeholder groups. So we're almost like a special district in that sense, created independently. But we don't have, I can't have a police force and I can't raise taxes.
So you're unique. I mean, is there any other model? Where did
Well,
the model come from?
During the last session, you heard about San Francisco Health Plan.
Yeah.
They're like us, and it's a model. Actually, the model came from something that, by coincidence, I helped develop in the 80s in Northern California, the health plan of San Mateo, which was the first one of these second county organized health system after Santa Barbara. And the idea at the time was Medi-Cal services are underfunded, but they need to be provided in a coordinated manner. And so managed care needs to happen. And for the benefit of Medi-Cal recipients and the state of California. But they were afraid of sort of unbridled competition, so they created these responsible public agencies. In LA and in San Francisco and 7 other counties, what they determined was that you couldn't just have competition among commercial players. You needed somebody looking after the safety net. So an LA Care was created and started operating just about 11 years ago. So that's how we got formed. Our responsibilities are, first and foremost, to provide services through direct services as well as through our plan partners, subcontracting health plans for Medi-Cal recipients. Our second responsibility is to protect the safety net, the clinics, the county hospitals, the county clinics, and private hospitals that would be otherwise perhaps disadvantaged. What is protect? In competition, there was a fear that once you started a competitive environment, that the folks that had been most responsible for serving the safety net, if they were or serving the Medi-Cal recipients, if they were in competition with private providers during various cycles of the economy or cycles of reimbursements, they would lose out because somebody could go to Cedars instead of going to county. Well, we've done it through a lot of different things, and that's part of why I'm here, I guess. One, we favorably assign people to public clinics and to the community clinics throughout LA County. We have made something on the order of $27 million worth of grants to help support the community clinics over time. Grants, right now, county hospital is about to be finished, a new county hospital. They ran into a problem where they didn't have a project management office to run the development of the new facility. So we helped fund a project management office. We have funded the creation of a variety of programs at clinics. We've helped put facilities in almost all the clinics in LA County now to help them serve people with disabilities, like scales that wheelchairs could be used with for people that don't have mobility, et cetera. So we do that. So we help to really help them get prepared to compete and make sure that they're not in such a competitive environment that they can't compete. So that's part of our responsibility. But we also try to improve care for Medi-Cal recipients. We just got our NCQA accreditation, for example, which is the National Committee on Quality Assurance. So I didn't want to talk too much about LA Care, but I wanted to give you some background as to who we are. It's a pretty interesting organization, and the model's interesting. relative to, say, San Francisco Health Plan, they had, before they started their new program, about, I want to say, 36,000 members. We've got about 720,000 members. So that gets to one of the issues that was talked about in the last session. Things are much more doable in the city of San Francisco. Things were much more doable when I started the health plan of San Mateo than they are in LA. So from a practical level, and the city-county relationship is unified in San Francisco. I would argue that there are some very important roles for the city in health status as it relates to poverty. I think that it's less so in the delivery of care, except for some supplementation perhaps to given clinics, et cetera. It's more in some of the other factors, creating an environment in which there are parks, creating an environment in which kids are protected from gang violence and other forms of violence. In an earlier incarnation, I was the president of the California Wellness Foundation, and the first initiative we sponsored when I started that foundation was a youth violence prevention program, a big one that's lasted until today, with some successes. But I would say that it's those kinds of areas where you have direct control over zoning, over building permits, over the provision of various kinds of safety services that you can have probably the biggest direct impact from the city of Los Angeles. That's not to say you shouldn't be partnering with the providers in the community. You shouldn't be partnering with the county when appropriate. They've done, there are a lot of complaints about Los Angeles County Department of Health Services. But and I'm not going to get into evaluating that, except to say that we have to keep in mind it's the biggest safety net, public safety net program in the United States. So the county has actually done a lot. Whether we like the way they've done various things or not, they've got a tremendously wide-ranging set of services here. And I think complementing that would be important, but I guess I would just emphasize that it's in looking at some of the areas around safe environments, nutrition, environmental pollution, et cetera, where you can have, as the city, tremendous impact on the health of particularly folks in low-income communities.
Now, do you do work on the in-home health care?
We actually administered the IHSS program, the in-home health service. We administered it for the county's health plan for about 4.5 years, and just this past year we turned it back over to them. But during the startup, they were concerned about not being able to do it. So we had done it until January 1st, I think, of this year.
I mean, my mother has Alzheimer's, and we've been dealing with a whole slew of issues related to her care, but one of them is the in-home health. It's so complicated, and
right.
It's so difficult to determine eligibility, and if one of the entities involved has certain criteria that if you qualify for, it sort of undercuts you in the other entity that has to be involved in the provision of the in-home.
Yeah, we were actually involved in administering the health benefit for all the in-home support services workers.
Yeah.
So I don't know. Fortunately, I can't take the blame, but unfortunately, I can't help you with it either, because I don't know the details of the eligibility around that, and I know they've had their own challenges lately. Lord?
I think it's administered at the state level as part of that state Medicaid program.
Yeah, it is.
Yeah, but
I have a brother
the
who's
standard,
severely
it's actually administered, I believe, at both levels, and the problem is that the standards aren't aligned.
Yeah,
it's very difficult
It's very
to figure
difficult.
out.
I have a brother who's severely disabled.
Unless you're extremely poor,
You have to
Right.
have no
which makes it
access.
easy.
Yeah.
it makes it easy.
Yeah.
But
Original
if you're
access.
typically, most of the people fall somewhere on the edge, and there's a calculation of how much they qualify for, and it's impossible to get a firm figure. It's
Well,
very difficult.
That's
But anyway, that's here and right
well.
there.
There's a piece.
The reason I mention that is because the assisted living issue, particularly for seniors, is just
Tremendous.
growing exponentially, and we've got to get a hold of that. Otherwise, we're all going to be strapped with the burden of caring for our elderly.
We just started a program this year where we're working with Medicare. It's what they call special needs provider or special needs plan under the Medicare program to do both Medicaid, Medi-Cal, and Medicare. One final thing I'd mention is just that when you talk about models for trying to cover people or provide services, that I would argue that what they did in San Francisco is great. It's probably not doable in Los Angeles because of size and complexity, and plus a lot of the people in San Francisco who work in San Francisco don't live in San Francisco, and so they get their services close to home, which is not covered by that plan. In LA, it's big, and so people do live where they work. The uninsured, and this is what relates to what you were just saying, the uninsured are made up of a lot of folks who aren't dirt poor, who are now in the lower middle income, and we found when we started the Healthy Kids program back 5 years ago now, we insured kids that were otherwise uninsurable. The majority of them are undocumented. Mm-hmm. And we found and the program has been just tremendously successful, except that it didn't result in state policy change because of health care reform failing. Mm-hmm. But what we found was that 3/4 of those families, who are almost all below 100% of the poverty level, had working parents, oftentimes both parents working, didn't have health insurance, didn't qualify for Medi-Cal. So that's another complicating factor here in Los Angeles. If you expanded the Healthy Families program, which is funded by state and federal government, to 300% of the poverty level, you'd still have almost all the kids who today are in our Healthy Kids program, and we've got today 32,000. We had 45,000 at the high point. None of those kids would be covered by that program. Just about none of them would qualify because of the documentation issue. So you solve the coverage issue as most people think about coverage, and you haven't solved the coverage issue in Los Angeles City or
Have
county.
any idea how we do that?
How we do that? That's tomorrow's description. Yeah, you know.
Seriously, well, there's no magic pill, but do you see, with the various proposals that are floating, what do you see as the top three potential gap closure measures that have some real viability?
I don't think any of them, as they're currently stated, will end up flying. I actually thought that the governor's proposal was a pretty good one, not because it really addressed our core problems, which also ties to cost containment, but because it helped eliminate one of the big problems, which was the discussion about coverage for most people, and it included all kids, including undocumented kids. So we'd be dealing with a more measurable problem at that point.
Okay.
But
Like Healthy Families.
it would be like, well, our program Healthy Kids is like that.
Solve all the problems, but it took care of a huge.
It took care of a huge piece of it, and it got us to the point where we are 97% of the kids of low-income kids
what
can
I've
get
said to
covered.
people-
Not in LA, but
What I've
nationwide.
said to people is that I don't anticipate any of the current proposals being the be-all and end-all, but that essentially in the United States we will create a patchwork quilt that will eventually get us to universal coverage. And we're going to use a variety of mechanisms to do it.
The problem is that, and now I'm putting on my health plan hat, if we don't figure out how to change the structure of the system, it will be fantastically unaffordable. We already spend 16+%.
It's already unaffordable.
It's already unaffordable. And part of the reason it's unaffordable to employers is the cost shift is so great, not from the uninsured, although it's partly from the uninsured. A lot of it's from Medi-Cal, because Medi-Cal underpays so badly. We're the best deal in the United States in terms of paying for care. It's the cheapest deal in the United States right now, rivaled only by Puerto Rico. So,
But I think it's important to note is that the federal solution will not take care of LA's large and documented problem and issues. That has to be a state solution. And there are state programs that do part of the job.
Well, we would argue that it should
Be
be
a
a
local-
federal.
Well, but
It's a-
yes, until we deal with the immigration issue
Well,
at the
that's-
national level,
that's
because
the key. It's
every
the
federal
immigration
dollar
issue.
that comes down has as it, you cannot, for the community clinics, to the coverage initiative, to Medi-Cal.
8 more days.
8 more days.
let's not go there now. But no, I
Don't
Mark's-
scare 'em.
it will not. You have to address the immigration issue. You can't solve the health care coverage problem for undocumented people through health care, it has to be solved through the immigration laws first. I mean, that's clear. Anyway,
And
talked
I
for
think
long
that's
enough.
something that, in fact, we would appreciate your comments in the document about the immigration issue and how, just what you said, we cannot solve the healthcare crisis without some real direction and resources from the federal government and closure on some of these issues.
You know,
I mean, the one thing Bush did try to stimulate was some discussion about how to deal with the immigration issue. And,
Just went the wrong way.
and of course, he wasn't able to get his proposal in, and I'm not suggesting I support it, but what I am saying is that
he did try to get it going.
he did try to get.
Yeah.
Well,
No,
he
to-
did
you gotta
get
give-
part of it going. I mean, the fact that they did it administratively and not through the legislative process, they now have tacked on requirements for Medi-Cal that are asking for documentation that heretofore it was not a requirement. And, you know,
Right.
don't ask, don't tell.
Well, but had the proposal been approved by Congress, it wouldn't have had such.
Right.
hard-
Yeah,
But he stuck around.
he had to go back to his base, and so he had to give up on that issue because they were the only ones still supporting him. You know, one of the questions you posed to us, and this will be the last thing I say, is what's the status of the safety net here in LA right now? And I would say, very sort of quick and dirty, there's three parts to the safety net. There's the public hospitals/clinics, there's the private clinics, and there's the private hospitals that are part of the safety net, the ones that serve a lot of low-income people. The clinics, I would argue, are in pretty good shape because the Bush administration has been supportive of the clinics because it was better than covering people. So the Bush administration provided good funding, and Luis can talk about that in a more eloquent way than I could, for nonprofit
For the federally
clinics.
qualified health center
Yeah.
program.
They've actually been pretty generous and the clinics have proliferated, and the challenge to the clinics is the future
Well, I know
and
that- I
the
know
and the
that-
massive demand.
I mentioned the 35 million in the primary care clinic. It was actually 85 million as a total, but for every allocation, there was a federal
Match.
match of some kind, and sometimes
Right.
it was 5 times the amount. And so I know that the federal government, every time a clinic was eligible for funding from the Community Care Clinic Act, they typically received multiples of a match from the
Yeah.
federal government. So.
And so they're in pretty good shape. The public hospitals, we read about it all the time. We understand the
Private
MLK
hospitals are
challenges.
in as dire.
But we have a new public hospital coming online within a few days, which will be a very positive thing, I think, potentially. The private hospitals is probably, I would argue, the private hospitals that serve a lot of Medi-Cal recipients or uninsured are probably the weakest link right now and the most threatened. And that could have disastrous effects. And it's not really the uninsured. You know, the old stereotype of uninsured using the ERs,
Right.
they use them at a lower rate. They use them at a lower rate.
Exactly, and I
So,
use that analysis in many talk points, that it's not the uninsured who will be negatively affected. They're already negatively affected. It's those who can afford to pay, but will have to pass 3 former hospitals to get to the hospital when they have a heart attack, and they might not have that much time. That's a dramatic example, but that's the reality. People are dying. And in fact, for the first year, I think last year was the first year that this nation has seen a lowering of the average age of death in 40 years. And I think it's not because we don't have the knowledge and capability. It's because we didn't have the political will to get us to the next step.
yeah, and political will is a big factor.
Okay, well, thank you very much. And again, we would appreciate your input on these. Yours is an innovative model, but it covers so much. It can't be ignored in the system. But more importantly, what's the next step? How do we go to the next step? And of course, on the issue of the immigration services, I would like to be educated, and hopefully you can have impact on our document as we make some suggestions with regard to that.
Great, we're happy to help out.
Thank you. Our next speaker, excuse me. We're not memorizing your names. Louise McCarthy
Sure.
from Community Clinic Association.
All right. Good afternoon, Council Member.
Hi.
Louise McCarthy, Vice President of Government Affairs for the Community Clinic Association. Just a quick who we are in that three-prong face of the safety net. The Clinic Association represents the private nonprofit community clinics throughout LA County. We have 42 member organizations that operate 127 full-time sites throughout the county, serving
How many in the city?
the county and the
Do you-
city.
Do you know how many in the city?
Within the city, no. We have not been
Okay,
able
I'd
to
appreciate
slice
if you-
and dice. We can get you
Could
that
you get that for
information.
us?
Sure,
Uh-huh.
we'd be happy to. We've done a lot of regional analyses, and I think that's one of the big challenges is how many ways can you slice and dice LA County, whether it's service planning areas, neighborhoods, cities, unincorporated areas. It's a real interesting challenge to try to look at how you actually frame something that's going to work for this complex network of cities and city and county all together. Our members serve about 1 million patients a year, providing about 2 million visits to those patients each year. When you look at where they sit in comparison to the rest of the state and the rest of the nation, LA's community clinics see a vastly more uninsured people than the state and national averages. The national average is about 40, I want to say 46%, whereas in Los Angeles it's 76% uninsured as far as our patient mix goes. We know that having insurance is an important means of getting access to services. When we come from the access model, the clinics see everyone regardless of ability to pay. If you're uninsured, if you're on Medi-Cal, healthy families, healthy kids, some clinics actually take private insurance as well. In rural areas, they are often the only provider that may be in a community. There are no private providers. So they're really the safety net system for low income and the working poor. It's really important to note, and I think in looking at the master plan, one of the findings related to the federal poverty level and how we actually look at defining what is poverty, it's really important to think about that in the context of Los Angeles. What is actually affordable for a family that's making $1,000 a month for a single person is 100% of federal poverty level, about that. That's not a whole lot. So when you start looking at what's actually affordable in LA County and LA City, the context of the federal poverty level, I think is important to say.
Well,
so just,
I can tell you as a fact that this city passed a resolution to ask the federal government to modify their federal poverty guidelines. And we presented that. I presented that to all the presidential candidates, and I can tell you that Senator Obama announced just a couple of months ago that he has incorporated it as part of his agenda. In fact, the language reflects the language of the resolution that the city passed.
I believe that in New York also has done some stuff around different measures for poverty.
Mayor Bloomberg has been very aggressive. I mean, it would behoove, I think, the mayors of the country to get control of this before the federal government gets control of it, because when they get control of it, it could have a negative impact. For example, Mayor Bloomberg increased the federal poverty percentage from, I think, 19% to 23%. But if the federal government had changed the guidelines to 30%, it would have had dramatic ramifications on the funding streams for the various programs that New York manages. So I think he did a very what's the word, a conservative approach to expanding the federal poverty guidelines. In actuality, in the city of Los Angeles, if you looked at self-sufficiency as the measure, which would be ideally what the federal poverty guidelines should be able to measure, we would be at 30%, and we wouldn't be able to. We would have to change just about every program that we implement. So as we look at changing the federal poverty guidelines, we have to look at it as a graduated program because it's going to have dramatic impacts on poverty, and all the definitions of all the bills out of Congress that have to do with social service provision that are measured by the federal poverty guidelines could be affected. So we have to be very careful how we implement that. And I actually see it occurring over a period of 5 years, not one.
And how we interact with our state and federal programs when it comes to the calculation of federal federal poverty level, you look at recently the Centers for Medicaid and Medicare Services came out with a directive. Well, it's been a while now since it came out, which essentially wanted to make a much more bright line of eligibility on our state children's health insurance program, Healthy Families. And in looking at this directive as well, they were actually calculating family eligibility for S-CHIP. So you had to get X percent of people under a certain percent of FPL enrolled before you could expand any services above that level. But the other piece about what they were looking at the federal side was they were basing it on gross income, whereas California was doing it on net. So just in the simple adjustment right there, and luckily we've got a state administration who was very wily and capable of pushing back and showing them that our state plan amendment just wouldn't allow for that. We already had it codified for our structures to be what Healthy Families is. So luckily we won on that one.
Well, I absolutely believe that the fact that the state of California gets 70% of every federal tax dollars we provide in return, I believe a portion of that has to do with the federal poverty guidelines. So you can bet, given my history with this subject, that there will be a very ample discussion about that in this document. But anything you can do to edify that.
So further parts, just in
appreciate.
looking at, so our patients, I think a lot of folks have already spoken largely to who the patients are of the community clinics. They're folks with jobs, their families, and they do not have insurance or they have public insurance for any number of reasons. They are often trying to navigate and get access to services and get enrolled in programs for which they may be eligible but are not yet enrolled. And that's an important thing to note, is a lot of the folks that we are seeing as uninsured may actually be eligible for public programs, but perhaps if the parents have a fear about their own status, that's going to be a prevention factor that will prevent them from going and seeking coverage. If you've got the ability to get the documentation. We went through a training this morning bringing in clinic application assistants to try to help them figure out how to deal with the federal government and the Deficit Reduction Act citizenship verification requirements, which say you've got to show an original birth certificate if you want to get access to Medi-Cal services. That's luckily we've got a state that's doing birth certificate matches and is doing everything in their power, and the county's been very helpful with this and all the programs. But there's another thing I noticed here in the master plan document is that you talk about there's a dialogue about outreach and enrollment and facilitating enrollment, making sure that the safety net providers have access to the resources to get more people enrolled, and that you've got more dedicated resources to enrollment, and not just enrollment but retention as well, because that's one of the fastest things that we see is it's not just getting coverage, it's maintaining coverage. If you want to reduce system costs for someone, an example at South Central Community Health Center, their doctor had found a lump of breast cancer on one of their patients. By the time he got her set up with a specialist, she's a Medi-Cal patient, by the time he got her set up with a specialist to treat her, she had missed a form on Medi-Cal and had to re-up, and it had metastasized by the time that they could get her back up onto Medi-Cal and back in to the specialist. So where's your savings there? How did this bureaucratic hurdle, which kicks someone off coverage to save a per member per month cost, suddenly that ends up costing the system largely?
Well, it's similar to the whole notion which created the expansion of primary care clinics, where you either send them to the primary care clinics or you send them to the emergency wards and pay 3 times as much. And I think that argument eventually
and I think
provided the impetus.
And
for expansion.
that's something that I think has been one of the really big challenges, is that when we look at systems-wide approaches to try to reduce costs, often these approaches are done in incremental steps, which politically is the only viable way to get something done. Comprehensive reform is a major challenge on any number of fronts, but the political front, it cannot be denied.
Well,
but those incremental steps, one thing, you start creating more systems for access, but there's such a great need out there that it's the tip of the iceberg and the tip of the iceberg. So I think, for example, getting facilities. The Cedillo Alarcón Community Clinic Investment Act of 2003 made a major difference on getting facilities statewide. And it was a beautiful measure that was able to attract federal dollars, private dollars, and it didn't say, looking at facilities, we will pay for the entire thing. When we look at the role of LA Care
With the
and other
association,
funders, they all
there's
come
something
together.
I've been trying to get for years, and that is, has the association ever been able to calculate what that generated in terms of resources? I know it was 85 million.
I know statewide we have the numbers. I can't tell you on the LA or city level or LA County, but statewide I could certainly give you that.
I'd like to get it statewide.
Sure.
But I know it was in multiples of greater than 5. I mean, because we were only giving these grants out for those who don't know of 250,000. Well, that's not going to build you a hospital, but to get a match 5 times greater than that, or I saw one project. I think it was up in Tiburcio Vasquez clinic up there. I think they got
Fremont.
a $20 million program that was able to or facility was able to emerge out of that grant.
And that's something that that's really pointed to here in the master plan is the importance of partnership. And I think that that's something that is an important role, is the fact that leveraging public dollars with private dollars, with getting parties to come together, because then also you've got a shared responsibility for the ongoing sustainability of this system. Looking at leveraging funds, thinking about the way that the city leverages funds in planning, for example, if they're siting facilities, if there are any types of locations that are being looked at for any number of services, those types of opportunities are the things that we as clinics look at as being ways to get more services into the communities. School health centers, for example, is a great way to get more services to places where students already go for care. And when we look at LAUSD, for example, they have joint use funding. And so when they're putting out their joint use funding, it's an investment, it's a beginning, but it does get us partway there. But beyond the facility side and looking at just leveraging state and federal dollars, school district dollars, any types of sites, there's also this side of services. And you can build an incredible clinic, you can build a beautiful facility, but being able to pay the staff that's there and being able to make it really operational is a major challenge when you have 76% of your patients walking in uninsured. Something that was interesting when the state Medi-Cal bills stopped getting paid. Well, we went quite a long time without any payments from the state Medi-Cal. And there was a real worry with the budget impasse at the state level that clinics in LA were going to start closing. And I was worried in particular about our smallest clinics. I started calling around and checking with them. How are you doing? How are you doing? Our smallest clinics, because they have such an unsustainable payer mix, they're used to living in an unsustainable environment. They have 90% uninsured at some of our clinics. The impact of a no Medi-Cal payment, what Medi-Cal payment? That's not something they ever get. So for them, it was a major sort of, we've never really had that problem. So they've been looking at funders, but we are going to see some major challenges for them with the economic crisis. One, you've got more people losing jobs, more people losing insurance, but also the funders and the folks that are really the bread and butter for these operations, the people that offset the cost of all the uninsured. They're out there in the investment market. So I'll close with that. I think just really thinking about the partnerships that are highlighted in here, the unique situation of LA and the federal poverty level, I thought was something that was very interesting and good to point out. Also, this concept of systems and coordination. The better that we coordinate our systems, the more likely we are to be able to reduce costs, like you were saying, of getting folks appropriately utilizing the ERs and appropriately utilizing their primary care providers. That's going to make a huge difference.
But I also want the document to adequately
Mhm.
cover the primary care clinic.
Yep. So what I'm going to do in follow-up, I'll provide you with a profile of all of the clinics that are in the city of Los Angeles, as well as the impact on it will be the statewide impact on the investment of the City of Alarcon Investment Act of 2003.
I just appreciate that on the side. You can get that to Saida Lee.
Sure.
The other thing that I hope to be able to bring out of this document that I don't think we've done an adequate job of is the economic development opportunities
Absolutely.
in provision of health care. We're providing 30,000 visas to nurses that we could create a stream of 30,000 nurses right from the local neighborhoods providing services in their own communities.
And the training opportunities, I think, are something that's really important when you look
But-
at the
but what
private
I'm
hospitals and the public
suggesting-
hospitals and the
What I'm
clinics.
suggesting is let's not keep looking at the streams of money that come down through the healthcare streams.
Right.
We need to start looking at it. Department of Commerce needs to invest in healthcare provision as an economic development strategy.
Absolutely.
And so I think we can expand the circle of opportunity. And those jobs can't go to China. I mean, they've got to be here. You know, a nurse cannot give somebody inoculation from China. So
She can try, but
I should mention that we funded a new program at All of You. It should be starting not too long time from now, a nursing program.
Yeah.
Started to get a nursing program funded because we're not producing enough nurses here locally. And
actually,
it
there's
was-
a very innovative project that we should incorporate an anecdote that Telecu is involved with. You're probably familiar with it. I don't know, but they have a contract with 5 or 6 major hospitals, including Children's and White Memorial, to train locally. Apparently, it costs a hospital, I believe it's $65,000 for every visa to sponsor that person. And if we can train them locally for less than that, and for some reason, the psychology makes it so that they're more loyal. They don't move when they get a better offer.
And the health
and-
professions are more than nurses too. I mean, when we look at community clinics training, their
Absolutely.
dental
Absolutely.
assistants, your medical
Absolutely.
assistants, those are jobs. Those are
Absolutely.
pure jobs, and the impact of those dollars staying in the community instead of going back as remittances to the home country, that also is a major point to make. So,
Okay, well, thank you.
thank you.
Okay, well, I think we covered a lot of your turf already. So, but Lark, you actually represent the community health councils, and so we obviously want to get your input as well.
Well, I appreciate the opportunity, and I should explain that Community Health Councils is not a direct service provider. We are, in fact, a health policy organization located in South Los Angeles, and our focus is around 3 issues: expansion and quality of healthcare coverage, the access and quality of the healthcare safety net system, and thirdly, the health of communities. And a lot of that is about economic reinvestment and survival. I'm going to, since I'm the last one, I can have fun with this, and I'm going to challenge you a little. First of all, I think it was a really well-done document, the portion that I did receive. I want to challenge you on a couple points. First of all, while I think it's an interesting concept to look at ending poverty, I want to suggest that maybe the focus, if not of this, of a future report, needs to be about creating a healthy Los Angeles. We know in the healthcare world that having income, having an insurance card doesn't guarantee you health, and it doesn't guarantee you access to quality health care. There have been studies that show that race matters. And race in this city and perhaps across the country has been a proxy for economic interest. And so we've been marginalized around race, and we have concentrated poverty around race. And so to speak only of ending poverty, I think, is to miss a critical issue. I'd also say that you said earlier that while...
Which issue?
I think it's the issue of racism, and I think it's also the issue of health, the right of a human being to enjoy a healthy life. And we're not all afforded that. And it's not simply because we don't have health insurance. It's about the environment that Beatrice spoke of earlier, that you're in communities.
Well, I'm going to come back at you and say, hey, you got to help us write it.
I don't have a problem doing that. I don't have a problem. Yeah, you may not want to make that offer to the public.
Because that's a very good point. I don't think we have, I'm trying to think, I don't think we have any chapter per se that covers the issue of, not necessarily racism in per se, but certainly the negative effects of
The implications of race.
the negative impact on communities of color and women and children. For that.
And I think what I have come to learn over my number of years is that public agencies, government has a lot to do with the status of health, the socioeconomics of communities, either through inappropriate public policy or an inaction around public policy. I look at just what's happened here in the Baldwin Hills oil field, for example, pretty affluent community. City of Los Angeles tried to weigh in. It's an environmental wasteland. The incidence of cancer and heart disease is off the chart compared to other communities, and yet we struggle with trying to regulate the exposure in that community. And the City of Los Angeles, as I said, has tried to have a role, but has not gotten there. And the Board of Supervisors is about to enact legislation that will really not do the job. So I believe that public policy can make a difference.
Well, let me ask John, because I created the first environmental justice committee in the state senate. So I thought we had incorporated some notions of environmental justice.
We do have some.
We
Maybe
have
in
a
another-
but it's
another
not
chapter,
It's not
not
in
in
this
this.
chapter. Do you know which chapter it's in?
It's going to be, there is going to be something that's going to be added to this.
In this chapter. Okay, so if you would help us, are you speaking of environmental justice
Well,
per se?
I guess I want to go back to B's earlier point and to challenge you on something you said. You said that the city did not have a mandate for health care coverage, and I think that's right. But I do think the city has a mandate for health. And when I look at things like your general plan, when I look at things around your parks and recreational opportunities, when I look at policing and I look at the services around children and family, I don't see in the city's language an understanding and appreciation of the impact on the health of an individual. So while you may not be able to put an insurance card in that family's hand, you really do determine their access to healthy resources. And that's why I say I think that this concept of a healthy community brings with it an understanding that there has to be an economic reinvestment in communities. We're about to release, and I said I would share with you, what we've done is a scorecard around the health equity, and we look at South Los Angeles. And we go across 50 different indicators that many of them have to do with the city government and its policies. And we find that the city has fallen short. And so the question becomes.
That you're saying this because I actually introduced a motion, and John, were you here? That we actually put a title on it that it's almost exactly what you're talking about. Something about for a healthier LA, and I can't remember. Said just left, but he would know.
Okay, I'll ask for that.
But no, I absolutely concur that it's similar to the idea that sometimes building and safety doesn't understand the economic impact of closing down a business for 3 days to fix the caulking on the floor, and we need to understand the health impact of the same thing,
right?
or other things that are similar. Not just in our certainly not just in our building and safety, but our police services. Actually, I think they actually have probably studied this more than other departments, but some of the other departments don't even look at the things from that view.
When I look at this document, and again, I think it's well written because it provides a very global perspective on these issues. I would challenge you to think more focused upon what the City of Los Angeles can do in terms of its policies and procedures. And that's where I think it may be a little lean and greater attention needs to be focused on that. We all get universal health care coverage. I think there's been a lot of discussion about that.
Yeah.
But there's not enough discussion about how city policy contributes and perpetuates not only poverty,
I would
but the
appreciate
lack
that.
of health.
And but again, I challenge you back
Okay.
to help us write it. And let me say that we have the constant concern that this document is not intended to be a City of Los Angeles procedure guide.
Okay.
It is global. We're not here to say what the City of Los Angeles can do to end poverty. We're here to say, how do you end poverty in Los Angeles? So sometimes we get overly global and forget about the city's responsibility. In this particular case, it's even more difficult because we don't have our charter doesn't say much about healthcare.
But
So
health.
and yet we have these I think moral responsibilities to understand how our decisions affect health. And so we would love to have your input on helping us write it in that way.
And a lot of it has to do with the distribution of your resources. When you look at the report that came out of City Controller Chick's office around the parks and recreation, and how, the Quimby dollars are not being used effectively, and how they're not going to communities. And great as he's smiling, I've hit a political interesting note. But I mean, there's some factual things that we can't ignore when we look at the funding around parks, when we look at the money that's going.
Yeah, the Quimby thing, I have to say that the concern I had about the auditor's report was that while I concur that the department was not necessarily in compliance with the intent of Quimby by moving dollars to different parks, and that they're not supposed to do that.
Yeah.
At the same time, the problem is not the Quimby fund, but the fact that the development dollars in that particular community are not contributing to it. So,
Well, so that's your redevelopment agent, and that gets into your redevelopment agencies.
but we don't have a lot of them, and the downtown redevelopment is capped, and so, but what I'm suggesting is that Quimby is not necessarily, maybe it needs to be rewritten.
Yes, I would
So that in a city like Los Angeles, we could take some of the Quimby dollars from one of the more
affluent or
uh,
park rich, let's put it that way, maybe.
well, not affordable. What's the term? You just said it. Affluent
Affluent.
community, from an affluent community, and shift it to areas of.
But I understand that rule is a city rule, the 2-mile limit.
No.
Are you
that is-
sure? Okay, that's what I was told. That's
No,
a
it's
specification in city law, not
It's a legal
state.
interpretation of Quimby.
Okay.
But we believe it's driven by the intent of Quimby, not city policy. Are you kidding? We'd be spending that money all over the place.
Well, but then so that's my other point, the leverage and the power that the city of Los Angeles has. I mean, you are a big elephant in the room. And so how do you use that power to leverage even the county, which is perhaps even a bigger, beast here? When you look at the nexus between your zoning and what the county has to do around.
Let's not focus on Quimby.
Okay.
I
No, I'm talking
I believe there are other funds where we
Okay.
have greater flexibility, but we
Prop
don't use it.
Okay, all right.
Okay.
So a question of equity about how you distribute your fund. Then again, the leverage that you have around zoning and what the county of Los Angeles needs to do around a more equitable distribution of healthcare resources. In the city of Inglewood, Daniel Freeman Hospital has closed. That city government has zoned that particular piece of land as hospital. They've put in a moratorium on what goes into that land, so giving them an opportunity to try to leverage healthcare services. Now, that may be controversial, but it provides an opportunity for you to influence the resources that communities have, and that's what we need to have happen. UCLA got that big structure zoned out there for more hospitals, a state agency that does very little for the uninsured, mind you. And yet, that was an opportunity to say, no, we don't need another hospital here, but if you put a hospital in another underserved community, the permitting of the city process will to support that. So there are opportunities I think you have to not only influence the resources that support health, but the healthcare delivery system itself.
Okay, let me, one thought that comes to mind that I don't want to forget
Okay.
is, I get a lot of these things, and if I don't get them out, they're gone forever. But one of them is that People in Parks has historically done a lot of good work on evaluating the provision of parks and how the city of Los Angeles is not very equitable in terms of the facilities that are provided in different communities. I think we should incorporate something about the work of people in park. Jack Foley is, actually he consulted Mayor Reardon, did such an effective report, the mayor fired him. It was, Jack is a professor out of Cal State Northridge. I've known him a long time, but he's absolutely dedicated to equity in terms of the facilities that we have in all our parks. But that's a good example. That does relate to healthcare, and maybe we should provide it as an anecdote or as an addendum. But let's just remember the people in parks concept. On the issue of the zoning, I'm troubled by that because I don't know how they did it around Daniel Freeman, but we're prohibited in many ways from rezoning something.
No, it wasn't rezoning. It was already zoned for a hospital, and so they were able to.
Okay, so I want to make that clear. Then.
Right. Well, it's the same. It's what Jan Perry's done with the fast food. It's the same concept that you're going through these plan updates. Consideration needs to be given to making sure that the communities have access to the healthcare resources. And you can do that through your zoning provisions. You do have some of that designation now. How do you preserve that? How do you designate other areas working with the county to ensure that if space becomes available, maybe part of redevelopment, the healthcare services are brought in there, that healthy food options, better supermarkets in inner cities where we know we do not have an adequate number. You got the major corporations leaving.
I think we have to be very careful there because, and it's like when you become a council member, the first thing is people tell you, well, we ought to have this here and we ought to have this here. And we don't own the property. We can't tell the property owner what to do with their property. Even though we can zone it in certain ways, we can't be overly specific as to take their rights away. And so it's largely driven. So there are incentives that can be created, and I'm all for that, and I've done it in my district. So, but at the same time, I recognize how difficult it is to when people say, well, we need a movie theater. In my district, we don't have one. I used to have one, but they redistricted. And so I lost the one that I created. So now we need a movie theater house in the northeast San Fernando Valley. But I can't tell the property owners, put a movie theater in. They don't want, they can't make it work.
When you're investing redevelopment dollars, and when you have that as a tool, the question becomes how can you leverage? It's about leverage. It's not about.
Absolutely. And believe me, having created a redevelopment zone, I'm well aware of that concept. But you're getting into areas that are.
We have to be bold. These are bold.
And I want you to be bold. I want you to be bold in your writing. And if even if I don't agree with you, I won't hesitate to incorporate your document for the public debate.
Consideration.
Because just the discussion moves us forward.
For me, at the end of the day, it's about health equity. It's about individuals' ability to live a healthy life. And as I said earlier, I don't think it's just about money. I really think it's about affording people the opportunity and the options to make healthy choices and to live a healthy life. And so the issue of equity is central to that. You cannot have health if we don't help to create equity in the systems and through policies that we have. Yeah. And so if you want to get serious about poverty, I think you have to get serious about the notion of equity. And I don't think that makes us a socialist.
Saeed, she was talking about a healthy LA. What was that motion I introduced and we put a title on it? What was it? I forget the title that we put on it.
Eos Sanos.
What is it?
Eos Sanos.
And now you're getting too smart for me. What was it?
That's what it was. It was
healthy.
Hijos. I didn't hear the hijos.
No, it wasn't that one. It wasn't that one. It was another one that we did. And I can't remember which one, but it was exactly the concept you were describing.
I'd love to see. I was on the Commission for Children and Youth and Family for a while, and I couldn't get them to the point where this city makes a commitment to ensure, as part of its mandate, that this is a place where children can grow up healthy. With that kind of a verbal commitment comes a lot of direction for policy. How does
Yeah.
policing feed into that? How does parks and recreations? How does community redevelopment? How do we create a community where children can be assured a healthy opportunity? That's where it begins. And I think that in the absence of that kind of vision,
Well, I actually believe that's part of it, but we're not going to exclude all the other populations while we're doing this report, because seniors can't wait.
Well,
And
a healthy community for all. I mean, I would love to go there. I was just starting the incremental notion.
yeah, no, I agree. I agree. This has been a very interesting discussion. The most important thing is that I appreciate the work that you do with my staff, particularly the interns from USC, who are volunteering for the most part to do this document. Your input, as much as you can provide, is absolutely essential to the quality of this document, and so we greatly appreciate it.
Can I just add one last comment, piling on what you were saying, Lark? We dance around it a little bit in terms of disparities and racial equality, or equality for all in terms of healthcare services. I've got to put in a final plea for really the health threats to the African American population in Los Angeles in particular. The problem for the Latinos, and I'm on the Latino Coalition for Healthy California, so I'm pretty involved in these issues, is there are some current issues, but they're really future issues, and a lot of them get resolved by coverage. That's an easy one, at least, to understand and answer for. In the African American community, the problems are so much more severe, and I don't think it should go unaddressed overtly in the city's plan, because a lot of them are not about health care.
Well, the mortality rate.
The mortality rates, the morbidity rates, the incidence of disability, et cetera, are just sky high in comparison to all the other groups. And
The healthy birth rates.
and they're about environmental issues, they're about issues of safety, they're about issues of the environment, both cultural and physical environment, social environment. And I just think that to somehow stake that out as something that is within not health care delivery, but health of the population is probably worthwhile looking at within the city's plan.
This document will be filled with chock full of anecdotes, and when I say anecdotes, I'm not talking about a couple of paragraphs. If it's a couple of paragraphs, it's a couple of paragraphs. But if it needs 3 pages, it's nevertheless something that's important. What I'm saying is that if we can do a particular view, analysis, provision of language in this document to look at the status of African American community. 40 years after the Civil Rights Movement, 50 years after the Civil Rights Movement, how is the African American community doing, given their prominence in the Civil Rights Movement 50 years ago? I would have no problem with putting that in as a perspective and inserting that in. One of the things we are doing with this document is inviting prominent people to write and incorporate their perspective in this document. Just the one that comes to mind is Mike Davis. We've asked him to write about poverty in Los Angeles. One of the guys from Culture Class, Ricardo Montoya, has agreed to write something as well. And Ariana Huffington, writers who are from Los Angeles who may be provocative but nevertheless add to the debate. And the worst thing you can do is not talk about it and not discuss it. And so so if there, I would think that the issue of the current status of African American health is an important subject that should be covered, and perhaps we can identify an African American writer of prominence who would make that statement for us.
Walter Mosley. Walter Mosley.
He's The other person I think that comes to mind is like someone like a Connie Rice, and there's been the
Connie
state
Rice
of
is the one that came to mind, in
yeah.
my mind.
They're doing they've done the state of Black LA, the state of Black California,
Something like that.
Yeah,
That would be
so
fun.
that's those
And
applications are there.
we might want to do that for other prominent ethnic groups. But with that, I want to thank you for your participation. I hope you will continue to participate, and we need you for this document to be effective. And I also appreciate personally the opportunity to discuss with you in committee, but more importantly, the work that we do with the staff. They work so hard on this. They generate these documents, and I just sort of guide it along. But thank you so much, and with that, this meeting's adjourned. Was there any public comment?
No, sir.
No public comment cards? Thank you very much.
Thank you.